Good evening, everybody. I apologize for being a little late. There were a number of things today, but due to perseverance and slightly irresponsible driving, I was able to get here. And so I'm grateful to you for being here. We're here tonight to discuss a very important topic, which is the opioid crisis, which is becoming an epidemic, and an extremely consequential epidemic at that, with all of the lives lost and people who are addicted. And we are facing a crisis which is increasing sort of logarithmically, if you will. And we have to get a handle on it, and that has to be everything from how we prescribe to how we monitor to alternatives that we offer, and opportunities. For example, to one of the bills I'm working on now is people get, let's say, 60 pills and they only need 10. What happens to the other 50? Often they wind up in a medicine cabinet, sit there for a while, wind up in someone else's hands, or thrown out, which also has its own problems. So we need a protocol to deal with that. And so there are a wide variety of things. One thing I would say, if I can just brag for a second about a bill we worked on before, there are a number of studies now that show that states with a medical cannabis protocol have a 25% lower rate of opioid deaths. So in Pennsylvania, we are averaging over 2,000 deaths a year now. So if that holds up when our cannabis protocol goes into full effect and becomes available sometime, I believe, in April, hopefully that will statistically, if that holds for Pennsylvania, be 500 lives a year or more that we save. But obviously it's not the only answer. There are a lot of other things. So I wanted to gather some experts together here tonight to give us some insight and some thoughts, answer questions that people have. So we're going to start with our wonderful county commissioner, Val Arkoosh, who is, I've heard her speak on this topic with regards to what the county is doing, and it's very impressive. And then she will turn it over to Kay, right? Who will speak to you, and then I'll introduce the rest of our panelists. And again, I want this to be informal. If there are questions that come up during this, raise your hand. I don't know what the protocol is for microphones, but there is someone's pointing. This is a microphone. Thank you. Thank you very much. And so I will do my best Phil Donahue impersonation and go around the audience handing this to people as they need it. But with that, I will, as always, reluctantly turn over the microphone to Val, and thank you for coming, Val.
Good evening, everyone. I really want to thank Senator Leach so much for pulling this together. There is so much information out there to share with the public, and it's so important that you're here tonight to hear that, because we really do need an army of folks that are working on this problem. And so I'm drafting you into my army tonight, and I really appreciate that you took some time to be here. I'm Val Arkoosh. I'm chair of the Montgomery County Board of Commissioners, and I'm also a physician. I practiced medicine for a little over 20 years before I moved into public policy and into elected office. So I am particularly passionate about this issue. This is, as the senator said, a very serious issue. In Pennsylvania, more people now die from an opioid or other drug overdose than from motor vehicle accidents. In 2014, Pennsylvania ranked 9th highest nationally for number of fatal drug overdoses. So we have a very real problem on our hands. This is a chart of what has happened in Montgomery County through 2016. You can see that we saw a pretty big jump up from 2014 to 2016 in particular. And I do want to tell you that in the fall of 2014, the county formed our opioid overdose task force. That happened when some leaders in our police community came to the then commissioners, Josh Shapiro and Leslie Richards, and said, hey, something is going on out there. Our officers are finding more and more people who have overdosed out in the community. You know, you need to really start to look into to this. And so our county formed its overdose task force in the fall of 2014, and we have been hard at this work since then, and you're going to hear some details about that. Now, I do want to give you a ray of hope in all of the negative data. This was just published in the Philadelphia Inquirer, and this was an assessment of Montgomery County as well as the surrounding counties. And I am incredibly happy to tell you that Montgomery County, which is that little blip that's moving toward the left, has experienced a 4% decrease in the number of deaths from an opioid overdose for the first half of 2017 compared to the first half of 2016. And I will tell you that we've actually had about 6 quarters now where we've been flat, which is huge because you can see what's happening all around us. Now, I want to be very clear. This is not a victory lap. We have a ton of work to do. Every single death is a death too many. But I do want to give you hope that working together as a community with all the tools that we have at our disposal now, we can make a difference in this terrible disease. And disease is what this is. One of the most important things that you can all leave here with tonight is the understanding that a substance use disorder is a disease. It has a genetic component. It requires lifelong treatment, but it is treatable. It's no different than having high blood pressure, diabetes, asthma, other diseases with genetic components that require lifelong treatment, but are treatable. One of our biggest barriers to getting people into treatment is the stigma that surrounds this particular problem. So this is not a moral failing. This is not a set of bad choices. This is a disease that certain people are more prone to than others. And it is, once you have it, you cannot just get rid of it. And if we can get more people into treatment, we can make huge progress. And Kay is going to talk a little bit more about that in a minute. So what are opioids? They are a class of medications used to treat moderate to severe pain. The legally available ones are available only by prescription, and some, like heroin, are illegal. The drugs that are currently available on the street now can be both natural like heroin, or synthetic like a drug called fentanyl. Fentanyl is a medication that is used in the operating room every single day, hundreds of times a day. I'm an anesthesiologist. That's what I practiced when I was doing clinical medicine. I can't tell you how many times a day I used fentanyl. But it's an incredibly potent drug. It's given intravenously in the operating room, and it is now widely available on the street, and it's incredibly deadly when given in too big of a dose. And so this is a huge part of our current problem here in the southeastern Pennsylvania region. People die from opioids because they make people feel calm, drowsy, and frequently lose consciousness. The drugs specifically work on a receptor that can stop your breathing. And so when people stop breathing, it's just a matter of minutes, 6 to 8 minutes for the average person before permanent brain damage starts to set in. And that's part of why we've worked so hard to make naloxone, which is an antidote to that, readily available in the community. And Kay will tell you a little bit more about that. So who's at risk? Well, anyone can suffer an overdose, but certain groups, at least here in Montgomery County, show up in our data as being more vulnerable than others. So in Montgomery County, men are 3 times more likely to overdose than women. Over half of the overdose victims in Montgomery County are between the ages of 18 and 33, although we have all age ranges, including up to people in their late 50s and 60s. And non-Hispanic whites are more likely to overdose than all other racial or ethnic groups combined. And I just wanted to give you a sense. Each of those dots, and probably within a dot, sometimes there's several, represents an area of the county where either one of our police or one of our emergency medical teams has given a dose of naloxone. And naloxone is that antidote that I told you about. I show you this slide because I want you to understand that this disease is everywhere in Montgomery County. There's not a place that's been spared. There's not a neighborhood. There's not anything that has been spared. In 2016, Our police and EMS first responders gave a total of 847 doses of naloxone in Montgomery County. That resulted in 627 reversals. So that's pretty good news because a number of those doses were actually a second, third, or sometimes even fourth dose to the same individual. And what we're seeing is with this increase of fentanyl out on the street, victims are needing sometimes 2 and 3 doses of naloxone in order to get them to start breathing again. So our police, fortunately, all 50 of our municipal police departments are carrying naloxone, as are all of our EMS responders. And so we have naloxone everywhere. We have it in many of our colleges, many of our schools. So we're very happy about that, but you can just see it's everywhere. I want to also just let you know, and I don't think we actually have this on any of our slides, so I'm going to say it and Kay will repeat it later. We have a website at the county that has all of the resources that Kay and I are going to talk about tonight, kind of as a one-stop shop. So it's a web page that then has links to all sorts of resources, including our Geo Story, which is a story that includes a lot of maps and things like this. It gives you a better sense of the problem here in the county. That website is montcopa.org/overdose prevention, all one word. So montcopa.org/ and then all one word, overdose prevention. And Kay will repeat that again a little bit later. So with that, I'm going to turn over to Kay McGowan. Kay is the director of our Department of Drug and Alcohol, and she's been at my side on this work for a long time. So, ladies and gentlemen, Kay McGowan.
Thank you, Dr. Arkoosh. I never know to call her doctor, commissioner, or just Val, but I can't just call her Val. I probably should have had this slide at the very end, so I'm going to come back to this, but I think that our ladies from Valley Forge can also talk to this issue about how to support and start that initial conversation with a loved one that you might have who you think has a substance abuse disorder. There are some guidelines that are given and that I'm sure I did not make copies to bring of the PowerPoint, but I'm sure if we get the PowerPoint to Dalen's office, he can make that available on his website or some way in his office. But there are some specific kinds of general guidelines that people want to follow when they are trying to talk to their loved ones for the first time, when they think that there's some kind of an issue. And they're pretty general, pretty basic, hard for you to read, I can see, but you don't want to talk to them when they're under the influence. You shouldn't be under the influence. You want to tell them what your observed behaviors of their behavior are and not get into an argumentative match, because you will lose every time, I can guarantee you that. I think individuals with substance use disorders, they are really good at manipulating conversations and whatnot. So you don't want to get into an argument about that. And ultimately, at the very end, you want to have a two-way conversation with them, but it's about observed behaviors, and that you are saying this to them because you care, that you would like them to have some help, and ultimately, at the end, you want to make sure that you have the resources available before you speak with them about where they can go to get some help. So that's the basics of how to help someone with a substance use disorder as a family member or a loved one who has no real training in it, but you're the one living the situation day to day with that person. So as, I forgot to turn that. We are the Montgomery County Office of Drug and Alcohol. We're embedded within the county's newly formed Department of Health and Human Services. So we are one office within a multiple number of offices of human services for the county. Primarily, our office provides a continuum of service availability, from prevention activities to intervention, which I'll speak with a little bit, to case management and assessment, and that's for individuals who are trying to get into treatment somewhere. We provide funding and resources available for treatment. The ladies sitting up here and some of the people in the audience are from Valley Forge Medical Center. That is one of our county contracted providers for inpatient detox and rehab services. We have a contracts with a multiple number of detox and rehabs, not just in Montgomery County, but across the state. And then we also have an opportunity for recovery supports in the manner of certified recovery specialists who are people in recovery, who work in, most likely, all of the ones that we are using right now work in a nonprofit organization. And they're people that have experienced and lived a life with substance use disorder, but they are in recovery now. And we have found that those are the best people to talk to the people who need the help. Intervention, I want to go back to the student assistance programs really are programs that are in every school district in Montgomery County. And that is for the kids in schools that have some kind of disruptive kind of behavior that could be related to a substance issue, but it could be related to a mental health issue. So every school district does have what they call SAP program or a SAP team. If you have a teenager or an adolescent who you think is dabbling in substances or there's some mental health issue of some sort, you can always go to your school district and ask to have them seen by the SAP team. But the brief intervention services, what I really wanted to mention is kind of unique with Montgomery County as opposed to the other surrounding counties. And I have a flyer on the back table with Dalen's information. And it really, we have 4 agencies located throughout Montgomery County. In this area, it would be Carson Valley Children's Aid, which is actually on DeKalb Street in Norristown. But family members, adolescents, individuals who may think they have an issue, but they're not quite sure, or they're not ready to really accept the fact that there is an issue, could go to one of those 4 agencies for free of charge. There's no insurance cost to it, and speak with someone about their loved one or about themselves. And those for 6 sessions, 6 one-hour sessions, and get some direction and advice. It's not counseling, but it's an intervention type of program so that it can help a family member if they're struggling with how to or what to say to their loved one. So that's available to any Montgomery County resident with no cost involved, no insurance accepted. And that list of provider agencies is on the table back there. Then the next slide just talks about treatment. There are various types of treatment that individuals can have. 24-hour care is on the left. Non-residential care, that is your outpatient, typical outpatient, where you go to see a counselor typically once a week. You might go to a group or 2 a week. There are different levels, again, in all kinds of treatment services that are available. Those services, we are very fortunate in Montgomery County. Not only do we have Valley Forge Medical Center, which is a large program. Greg, help me out, number of beds that you have? 86 beds to treat people in detox or rehab. I think Eagleville Hospital, not far from Valley Forge up the street, has probably close to 300 beds. 300 beds for detox and rehab. And then in the Willow Grove area, Malvern Institute, they have a pretty large program too. They're probably around 100 beds. So we have almost 500 detox and rehab beds just in Montgomery County alone. And I was just speaking with Greg Slocum, he's the CEO for Valley Forge, and he's at just almost 100% capacity. And I could say the same of Eagleville. I just came from there, and I bet if I called Malvern Institute tomorrow, they're at capacity with their beds. That's a lot of people that are getting treatment, are getting help. This crisis with opiates in particular, though, is causing an issue with bed capacity across the state. And we are doing our best at the state level, and we realize that, acknowledge it at the county level. That's why the commissioners are very supportive of our office having contracts with detox and rehab facilities outside of Montgomery County. So we will send someone to Harrisburg, to the Poconos. I think our farthest contract might be Williamsburg. I think it's Williamsburg, Pennsylvania, down near the West Virginia line. But we don't confine ourselves just to the beds, because those beds are being filled at Valley Forge and Eagleville by individuals from other counties as well. So the state system is set up in such a way that we share resources across the state. Priority populations. For our office, we are mandated to, yeah, was there a question?
I have a question, if I remember now, on the number of beds and the treatment, because I kind of categorize it. You have oral opioids, you have heroin and alcohol for these detox and treatments. Can you give me an idea, or give us an idea of how that divides up of the inpatient versus like outpatient?
The percentage of people that in those beds or in outpatient slots
For those categories.
for,
Because obviously heroin might be increasing, but there's still the alcohol.
oh, absolutely. And what I can tell you is, I didn't bring the statistics with me, but I did just see some the other day, because we're adding them into our geo story on our website. We have seen right now all opioids. That would include heroin, fentanyl, Percocets, Vicodin, all of the narcotic medications we classify together. We do have a breakout for each, but we're just looking at all of the categories of opioids. 65 to 70% of our admissions for residential detox and then rehab are for opioids. That, up until probably 6 years ago, was a total switch. It was much more 60-40 alcohol versus opioids. We're now opposite that. And that holds true in the outpatient setting as well. Because a lot of the individuals who are being admitted to detox and then rehab step down to outpatient. So when they come into outpatient, their identified drug of choice is an opioid. So it's pretty high, significantly high. But that does not mean that Valley Forge is not treating people with alcoholism. And that does not mean that we do not recognize alcoholism as a very pervasive issue in society, and that people also die from that. It just takes a little bit longer, a lot longer than it does in the current opioid situation. But people are getting treatment for all kinds of substance use disorders. Because of the way that the county receives funding to do our services from the State Department of Drug and Alcohol, who receives funding from the federal government, we do have certain priority populations that, just in case we run out of dollars or we get light on the dollars during a fiscal year, we have to prioritize preferential placement into treatment for these 5 populations. Obviously, pregnant injecting drug users, pregnant substance users of any substances, injecting drug users, overdose survivors from the opioids, and alcohol as well, and veterans. Those are our priority populations. This is an important slide to kind of try to understand with funding for treatment. Obviously, if family members are well endowed with financial resources, you can obviously pay privately for treatment. There are a lot of treatment programs. I shouldn't say a lot, I don't know how many, but there are a number of treatment programs where that is the sole source payer, is families pay privately. But there are also other alternatives. And private insurance, I would say, would be the second category. And it's important for all people to know that there is a law in effect in the state of Pennsylvania called Act 106, and it's managed out of the insurance department at the state. that requires any insurance policies written in the state of Pennsylvania to cover substance use treatment services. Now, there are caps on that, but they are mandated to cover that, 7 days of detox in a calendar year, 30 days of rehab in a calendar year, and I think 60 sessions of outpatient services. But they are mandated to do that under the Act 106. And our treatment providers are pretty awesome about when a private insurance company tries to say that the person only needs 2 days of detox and 7 days of rehab. They're very adept now at, when they're calling a private insurer, to say, you know, Act 106, we still believe that clinically this person needs to stay in treatment and they have insurance and their eligible days are available, which is a great thing. So that hopefully the insurance side will agree with the clinical side that the person can stay. And then you have the populations, veterans benefits obviously do have some. There's some issues with waiting lists and whatnot. But when that occurs, we now have the ability to use our dollars to pay for veterans if they can't get into the treatment that they need right away, even if they have the VA benefit. And then the other two populations are the public health clients. Those who have medical assistance, which has really skyrocketed. The medical assistance expansion has really improved people's ability with a substance use disorder to get treatment, to get help. And in Montgomery County, the way that program is designed, it's run through an insurance provider, Magellan Behavioral Health Services, who covers services for the Medicaid population. So if someone is on Medicaid, medical assistance, under our Health Choices contract, that is who oversees funding for individuals in treatment. And then Montgomery County is the last because, and it's right now the smallest, 3 years ago, before Medicaid expansion, we were the largest provider for funding for people with substance use disorders. So we were paying for, statistic I just saw yesterday was like between 700 and 800 residents of Montgomery County for treatment services and detox and rehab in 24-hour care. When Medicaid expansion came in 15-16, fiscal year 15-16, that number had dropped because a lot of those individuals became medical assistance eligible. And for us, our number dropped to about 300. So it was quite a switch of funding. So when you hear the federal government discussing the ACA, Obamacare, and changes to those stipulations within that law, and they talk about Medicaid expansion and taking that away, that is really would hurt a lot of people in Pennsylvania, not just Pennsylvania, across the nation. So we are there to pay for primarily the uninsured and underinsured individuals, people with no private health insurance and people who aren't on medical assistance, and that's who we pay for as a county. And the way you do access those services is by having the person go to one of these 3 sites. We kind of have a geographically split up. People in this section, central region of Montgomery County, would be seen by an assessor at Gadenzia in Norristown on Main Street. And their phone number and contact information is there. We have a site up in Pottstown, and then Gadenzia also operates the 3rd site over in Willow Grove area. When a person goes in there, they will be assessed for substance use issues and hooked up with the right treatment level of treatment that they need. Montgomery County's initiatives that usually Dr. Arkoosh goes over, but we have, as she mentioned about naloxone, all 50 of our municipal police departments now carry naloxone, so they are saving a lot of people's lives. The standing order is something also that Commissioner Arkoosh did, which was wonderful, and she might be able to just talk about that. This is the easy way I explain a standing order, basically, and tell me if I'm right, Dr. Arkoosh. You wrote a prescription for Montgomery County residents to be able to go to participating pharmacies, which is also, those pharmacies are identified on our Montco PA //overdose prevention website. Any of those participating pharmacies are accepting Dr. Arkoosh's, and now I think the other doctors, prescription. You can go there and ask for a kit for naloxone, and that pharmacy will give it to you. You don't need to go to your personal doctor to get that prescription.
You do have to pay, so if you have insurance, your insurance information, but you don't have to go through the step of getting a prescription from a physician.
Right.
And then the state physician general, Dr. Rachel Levine, has also, after I did mine, wrote one for the whole state. And so a number of the bigger chains, like giant food stores, CVS, drugstores, are using her prescription. But between the two of us, you can go to many pharmacies in Montgomery County and just walk in and say, go to the pharmacy and say, I would like a prescription of naloxone, and it will be dispensed. And what the cost will depend on your insurance and copay and things like that. And we do have a program for people who can't afford the copay. We do have a small number of doses available at our 3 county health center sites, health department sites, for someone who cannot afford the copay or doesn't have insurance.
Correct. And in addition to that, we really are trying to get naloxone into as many people's hands as possible. So besides the county health clinics, we are sponsoring 3 quarterly naloxone education and distribution events. And there is a card, again, back on Dalen's table that tells you where those events are going to be. The next one is coming up in December. I don't remember the exact date, but it will be held at Eagleville Hospital. So we're trying to move those sites around. We held one in September in Glenside. So the next one will be in Eagleville, central location, and one will be held out in Pottstown, and then we have one that will be holding up in the Pennsburg area of the county. So that's the other way that we're trying to distribute. There's a registration to register to attend one of those events. It's about an hour long, if not less, an hour and a half, but no more than an hour and a half. And it's really nice because we have included a family member who's lost a son or daughter to an overdose. So that we start the program with that person speaking, talking about their experience. Then our health department nurse goes into the distribution and training of an individual to use the nasal spray is what we're using. And then someone from my office will be there to talk about treatment options. Warm handoff projects are starting and happening in different locations. What a warm handoff is, so we have a lot of people overdosing, a lot of people surviving, thank God. And 92% or more, I think, are agreeing when they are revived to go to an emergency room for medical treatment because that is advisable. So a warm handoff project, which is a statewide initiative by the State Department of Drug and Alcohol Programs for every county to implement, is to have someone from the treatment world go into that emergency room to try to engage and connect with the overdose survivor. Preferably, we like to have a certified recovery specialist, someone who is in recovery themselves, to be that first point of contact. And that is happening in most all of the hospitals now, but it could be a clinician who has experience in just making sure that they can get someone assessed to go right from that emergency room department to a treatment program so that there's a warm handoff and the person isn't just walking out the door. A lot of our patients, or a lot of the patients that, as we have gone around to the hospitals, the 9 hospitals in Montgomery County, have indicated to us that when these individuals are revived, they come in, they're medically stable, the first thing they want to do is jump up and run out, and in fact, that does happen quite a bit. So because we don't have the resources to staff someone 24/7 in that ER to catch that person before they run out the door, unfortunately, that is happening quite a bit. It's just part of the disease, and when individuals are revived from their overdose, they're in a detox, they're in withdrawal, so the first thing is in their mind is that they need to go out and get drugs to make them feel better. So we're working on different plans, trying to talk about different ways to attack that problem. Montgomery County was fortunate also to have been selected, well, Montgomery County wasn't, but 2 providers within Montgomery County were selected as a center of excellence for opiate use disorders. And that's a kind of a team approach to get, again, reaching out. We have one of the centers of excellence is here in Norristown called Resources for Human Development. And they have a team of individuals, 2 certified recovery specialists, a nurse, a team lead, and 2 assessors. That they're a mobile unit, and they will also go out to hospitals wherever someone has an opiate use disorder to engage those individuals who aren't in treatment yet to get them into treatment. And then the other center of excellence for opiate use disorders is in Pottstown, and it's embedded physically. It's a federally qualified health center, so individuals can get medical care there, as well as they're physically located with our largest provider in Pottstown, Creative Health Services. So it's a nice match and nice relationship because Creative Health does our assessments for residential treatment, as well as they have an outpatient clinic there for substance use. Drug take-back program. There is one coming up this Saturday around the county.
Yeah, 41 locations.
41 locations. This is where you take your drugs and dispose of them to get them out of your house so that if you have any kind of addictive medications in your house, your children, your grandchildren, your nieces, nephews can't get a hold of them. If you're selling your house and you're having an open house, the visitors to your house can't get into your medicine cabinets and steal your addictive medications, because that does happen. And in fact, our district attorney was just at a Realtor Association meeting with 2 of the other district attorneys from Chester and Delaware counties to talk to a group of realtors about house-proofing their houses with the medications in their homes, because people are very smart and they will find how they can. My predecessor boss was just telling me how she had a cleaning service come in and she noticed that some of the probably 3-year-old Vicodins that she had from some teeth surgery, but that she still had in her cabinet, were stolen. And she did a sting operation and figured out that it was the cleaning crew that she had coming in. So anything you can do to get rid of those medications. Disposal sites at 41 areas, mostly all of the police departments have one. I'm sure there's one in this building. I think the police department is in this building. Take them there, and I also found out that Bucks County is #1 in the state for the amount, the poundage. But they are very,
Those are
very
fighting
nervous.
words. Now we're going to have a thing.
They are very nervous because Montgomery County has really stepped up, and we are very close to catching them. So we'll have to get that.
This is not just for opioids.
No, it's for
Yeah, you can
anything.
take anything.
I'm a pharmacist, so
Yeah.
there's a real problem with people just throwing old medications into, down their sinks.
Yeah, don't do that. Don't flush them down
And
the
that's what we don't want.
This is a great service.
Yeah, and it's all free, and you can
Yeah.
bring anything, and nobody talks to you.
No
It's completely
questions asked.
anonymous. You just go in, drop it off.
I can't tell you how many, I don't know, high blood pressure pills when my mother died, any of her medications, and she wasn't on any opiates. And then for the last 2 years, we had a billboard competition run, designed out of our house, where we've asked all of the Montgomery County high schools and middle schools to participate and have students that are in their art programs do designs about prevention for substance use or prescribing practices. And what the outcome is, it's a public vote done on the county website when we have the finalists posted, and the public goes on and votes, and the design with the most votes gets their creation put on 15 billboards throughout Montgomery County. I should have included a picture, I guess, in here of the young lady from Plymouth Whitemarsh High School. High school. She was a junior who won last year, who actually took a picture of herself and had a very good caption to it in her photography class. And she had her poster up on 15 billboards throughout Montgomery County, which is pretty cool, with the number for the county to call for anyone wanting to get some help. And with that, there are numbers listed here for giving the county health department a call, our office a call, or Magellan Behavioral Health, which is a person with Medicaid or medical assistance. And one more time, www.montcopa.org / overdose prevention. Check that website out. And with that, I'm going to, Dalen, would you like to introduce our next speakers?
Well, thank you. Thank you, Kay, and thank you, Val. It was very comprehensive and very helpful. We now have two more panelists who will discuss it in which order are you guys going? First, we have Amy Storti, who's a counselor, and then to spare people the necessity of seeing me yet again. After that, Terri will come up, and she's executive nurse, and you guys will talk about treatment issues, et cetera. So, the floor is yours.
You know what, I'm gonna go sit there because it's too hard to turn around.
Hi, actually, I'm Terri, and I'm going first.
That's okay. You have to save the best for last. And some of what I'll talk about will be a repeat of what's been said. Hopefully I can deliver it in a different perspective. But on a bigger scale, current trends with the opioid addiction include that there's been an actual epidemic declared by the United States government. 3 to 5 million people are currently addicted to opioids. Rates of prescription opioid abuse exceed any illicit drugs. 18 metric tons of heroin is consumed each year. I want to talk a little bit more about prescription opioid use. In 2010, enough opioids were prescribed to medicate each adult in the United States every 4 hours for 1 month. Vicodin, which was mentioned, was the most prescribed controlled medication on the Medicaid formulary. There's much easier access, which has been discussed already tonight, to prescription opioids. Pills are generally perceived as more socially acceptable and safer than heroin. Nearly 78% of all of those with opioid addiction, including heroin, begin with prescription opioids. Approximately 50% of injection heroin users report using prescription opioids prior to heroin. Fentanyl, which was already discussed, is a powerful synthetic opioid analgesic, which means that they can manipulate it or forms of it to be even more desirable to the receptors that it fits in. We'll cover that a little bit more later, but it's important to note that it's synthetic. It is a Schedule II prescription drug, typically used to treat patients with severe pain or to help manage pain after surgery. It's a potent, high-affinity, full agonist opioid, which means that it can sit in those receptors that bring the feelings of safety and happiness. It can sit there longer, and it does not show up on conventional opioid UDS tests. Sorry. Heroin and opioid overdose are now the leading cause of accidental death in Pennsylvania.
Nationally, prescription overdoses exceed heroin and cocaine overdoses combined. Approximately 175 people die of drug overdose every day in the US. And you can stop me at any point because I don't have much filler. In 2000, there were approximately 18,000 deaths from overdose. In 2016, there were more than 64,000 deaths. That's a graph because it's obligatory. But it does show that the synthetic opioids, other than methadone, is that big blue line, and it exceeds the methadone, methamphetamine, cocaine, and semi-synthetic and natural opioids, as well as heroin. I think that the good doctor covered naloxone. So I'll skip to the next one. Efforts to address the epidemic. Medication-assisted therapy. Methadone, buprenorphine, and Vivitrol. That's not how you say it, but it won't come to my head right now. And they have the implantable form of that medication, which was approved by the FDA in May 2016. It leads to a 58% decrease in inpatient charges when medications are used, a 45% decrease in hospital stays, and a 66% decrease in the cost of opioid drugs. I bring up that point because you'll see at the bottom, 11,000 CHF-related deaths per year and they get approximately 20 medications to treat CHF. There's over 64,000 overdose deaths, and we currently have 3.
What's CHF?
Sorry. Chronic congestive heart failure, sorry. Thank you. The PDMP. It's a monitoring program where doctors can look up the history of somebody who's about to be prescribed a narcotic, specifically an opioid, so that we can collaborate better and maybe identifying or treating an addiction. Other efforts to address the epidemic is access to effective treatment remains challenging. There's an overwhelming need, there's a lack of treatment resources, and there's a disparity of funding. Oh, that's it. Where's my brain slide? There was a brain slide. All right. I'll let Amy go. Thank you.
Hi, everyone. Oh, sorry. Yes.
Your last slide really hit on what caught my attention. So you were trying to catch this, and I believe it was the PA part brought it up. But my question is, with those medications that you have to treat, and you mentioned methadone, okay, it's being used to treat it, but now with this epidemic situation, everybody's in a scare or uproar. So the insurance companies themselves are falling back on allowing these to be given to the patients. You know, they're making it much harder. So leading to my question is, now that it has become to get so hard for people that need these medications to help treat them, does that make it an easier road to go back to the narcotics? It may not be what you want, but is that, you know what I mean? You see what I'm saying? Because it's harder to get what we have out here for treatment. And we're making it harder because we watch it.
I know that it works when they do.
Right. We know that it works, but now it's harder for them to get it because the insurance agencies are less at liberty to prescribe it. Or based upon the regulations, it's making it harder for them to get it.
It's making it hard for them to get the meds that treat the addiction.
Well, I think what you're referring to is that there are unfortunately some doctors out there that are just prescribing treatment without any, they're prescribing drugs without putting people into an actual treatment program. And so that doesn't really help anybody. It gets them pills, but it doesn't really get them treatment. as I said earlier, this is a disease. It's a holistic treatment approach to actually get someone into recovery and help them stay in recovery. So what the insurance companies are cracking down on are these doctors that are just pill mills, and they're just writing hundreds of prescriptions a day. You couldn't possibly see that many patients and evaluate them and do the proper things that a normal doctor would do. So that's what they're cracking down on. They're not cracking down on legitimate folks like this that are providing good, solid treatment to people. So, the other thing that's happening, though, is that there's a lot of regulations that are being talked about in Harrisburg right now, and there's already some for children, for minors, that will limit how many days of an opioid prescription can be prescribed. So right now, if you're under 18, I think it's 5 days or maybe 7 days. And do you remember, Dalen? Is it 7 days? I think 7 days. And I think that bill now for adults is making its way through the House and the Senate in Harrisburg. But there are exceptions for people who have cancer pain, chronic, legitimate diagnosed chronic pain, or people who are in treatment for substance use disorder. Yeah.
Most insurances cover for Vivitrol too.
They're starting to, I think, yeah. It was a comment that most insurances are covering for Vivitrol, which is a very effective medication-assisted treatment.
Let me make a comment in favor of opioids. I'm trying to belittle anything else. But over 20 years ago, my wife just came into somebody's house and broke her ankle. Unfortunately, is this switched on? Unfortunately, at the time, she was working at Abington Hospital. And she was in the Chief of Staff's office, and he said, your ankle should be improving by now. And sent her to an orthopedic surgeon, and in time, they determined that she'd got something called RSD. I don't know if any of you have come across this. It was actually first recognized in the American Civil War when one of the surgeons saw that it was taking longer for some patients to recover than would be normal. And then it became called RSD, and now it's a company called CRPS, I believe. Yeah. So my wife had that. Various treatments, some of the treatments are the ones that, basically what happens, there are physical signs in the ankle. You can see the skin is discolored, it gets hot. So this is visually, you can see there's a problem there. It also spreads. So in my wife's case, it went from the left ankle to the right ankle as well. If it's not detected early enough, it can go to almost any part of the body. It can happen in surgery. They don't know why it happens to some people and not others. Anyway, the bottom line is she started off with some medications that are used also in epilepsy in those days. She's on Clonopin and gabapentin. This is never going to go away. All it can really do is hold it back. And she was on Tylenol and such like for a long time. Finally, unfortunately, she was a recreational drinker, so she ended up drinking more than she should to alleviate the pain. She'd put off going on to low-level opioids for a long time. Finally, she did. She'd been with the same pain management doctor for a long, long time. And one thing which puzzles me a little bit is if I wanted a prescription for the opioid, if he was in surgery, I had to wait until he came out of surgery to give him the prescription. Occasionally, one of his reports would give it to me. But he controlled those prescriptions because he's a senior person. But nobody else gave me a prescription except him personally. And if there was some reason why it couldn't be, it'd be somebody else. So this is a puzzle to me, how all these prescriptions are. From my point of view, the concerns I have are that I think this is Cigna. They're not wanting to prescribe one of the opioid medications except for hospice or cancer. And the RSD organization makes the comment that scientifically, pain is pain, whether it's cancer or a chronic pain. I know that the type of regulations My wife has to go to the pain management doctor once a month to get the prescription instead of more often and less frequently. And also, she's got to give a urine sample to make sure she's not selling the pills on the streets of Bluebell. So that's the situation, and I'm concerned that they're going to clamp down and make it difficult for people to or more and more. Yes.
I think that concern is, I share your concern, and I think that at least, and I kept a very close eye on legislation in Harrisburg. Each piece that I've seen specifically has an exemption for chronic pain like your wife has. She's with a treatment provider, she's got a diagnosis.
It's being watched.
So it's, oh, I'm sorry. So she's, got a clear diagnosis, she's with a credible treatment provider, and there's no move to take away medications from someone like your wife. And I think there's quite a bit of understanding of how important that is. Yeah, so thank you for raising that.
Say two things. I asked about what's going on at the moment, is it going to have any effect? Probably some people might not like it. He said people are weak. And by that, he meant there's an awful lot of people who do not expect pain in their lives. And if they are 200 pounds overweight and they've got back pain, then you need medication to fix that, not lose weight. And the other one, he said that pharmaceutical companies have got to work on some alternative, and they've been loath to do so for many, many years. Now they're realising they probably have to do it. And there's a big article in the New York Post on this company that's been promoting overdose for years and years and years to make millions of dollars. So, I'm sorry, I'll stop.
No, but we hear you, and I think Senator Leach agrees with me that that is not the goal of any of this, is to make sure people like your wife get their treatment.
Can I address what you said, that you're saying that it would not?
It's just being live streamed to other people. So if we could talk into the mic, because otherwise they just see the lips moving.
I want to address both of these, because I'm a pharmacist. I also have chronic pain. I had back surgery, and I go to the same pharmacy. I go to the same doctor, just like the gentleman. You sign a contract, okay? It's monitored. I'm a diabetic. There are limits on what I can take. Non-steroidals are not an option for me because of potential kidney disease and other concerns. I have, X-ray documented problems and surgery. So what I'm seeing though now is with CVS, okay, who I've used for years. I have been told that, and I'm not sure if it has to do with your legislation or if it's CVS, they said for the first prescription, now this might be for a new patient, it's going to be limited to a 7-day supply, okay? And I got a letter in the mail that said now CVS, this is a policy they're going to have, they're going to limit, instead of a 30-day supply, they're going to limit to a 25-day supply. And to me, that's interfering with the doctor-patient relationship. And I don't know if this is part of your legislation or if this is a policy with CVS.
Well, it's not, my legislation does not deal with the front end. It does not deal with prescriptions, how much you can get, how many days supply or anything like that. My legislation deals with the back end. I would also note that it's not passed yet, so nothing is happening as a result of it. But what it would say is right now, in many circumstances, it's illegal for the pharmacy to take your medication back. So if you have 50 extra pills, what do you do with them? So we want to create a protocol where they can be returned and disposed of appropriately. Maybe even, I would like in a perfect world to create an incentive, sort of like we did with the bottles, recycling bottles, that you get some money back when you return pills, even though they can't.
It's against the law.
No, I know currently there is, but we're trying to change the law.
But you can dispose of them. That's not against the law.
No, you can throw them out. That's not illegal. Pharmacy, but right now they won't accept them. So we're trying to create something and, to incentivize people. Doesn't even have to be cash. It could be anything, because we find that, frankly, people are more likely to do it and go to the inconvenience if they're incentivized. It's all about how to get rid of excess pills, because there's a lot of excess pills. I know I had minor back surgery like 4 years ago, and they gave me a prescription of Percocet, and I took 2 of them, and I never took any more because I just didn't like it. Sort of made me feel like a zombie, and I made the mistake of doing a television interview after I took them. I'm sure that's on YouTube. But anyway, the point is that I didn't want them anymore. And so when there's a lot of extra pills, we want to figure out a way to do with them. But in terms of, look, the hardest thing in legislation, and that's true at the county level, it's true at the state level or the federal level, when you're dealing with a complex problem, is to pass something that addresses everything you want to address, but nothing you don't want to address. In other words, it's always, some things that you wish were in it that were out, and some things you wish weren't in it that were in. Drawing that line is the hardest part of it. So we don't want to give, unlimited supplies for people who only need a little bit, but on the other hand, we don't want to make it hard for people who really do need more to get it. So that's something we're all struggling with, I think. Did you want to weigh in, or anyone?
Oh, no, I'm okay.
Any other questions? Okay.
Yeah,
you want to speak, right?
Whenever you are ready.
People are chomping at the bit, but Kate, can you wait for her, let her speak for a minute? And then we'll go from there. I'm sorry.
Okay, great, thank you. Okay, hi everyone, my name is Amy. I am one of the counselors at Valley Forge. I also am a recovering drug addict and alcoholic. So me being up here tonight is a little bit different than what we were kind of talking about right at the moment. I was asked to come and explain and talk about my experience, what happened, and what I did about it, and where I am today. So, I'm not one of those type of people who, when I share my story, I get into this childhood and all this drama. I pretty much grew up, I feel like, in your typical family. There were issues in my family, as I feel there are issues in majority of people's families. But for me growing up, and this plays a big part in my addiction, I always felt different from everybody else. And what I mean by that is I always had this feeling inside of me that there was like a lack of love, that I wasn't good enough. And I could have been the Queen of England, having thousands and thousands of people love me and have all this attention, and I still, inside of myself, would not have felt loved. I learned through my addiction process and being in recovery that I had a me problem. And so looking back now, it makes total sense. I blamed everybody, and I used that as a victim card, which fed further into my addiction. I started drinking at the age of 12. That was my first drink. And quite frankly, I don't remember any of it, so I can't even tell you if I liked it or not. There was a boy up the street whose father was a pilot. And when you're on the airplane, they have the little bottles of alcohol. Well, he would collect them, and there was like this big cabinet of all these little liquor bottles. So my friend came down, he's like, oh, look what I have. And we drank them, don't remember. And after that, I didn't pick up another drink probably for about another year and a half. I was about to turn 14. It was the summertime. I was summer going into high school, and I started hanging out with the wrong crowd already, started drinking. And I remember at that point absolutely loving alcohol. I remember that having no feelings. I could relax. I wasn't stressed out. I wasn't upset about anything, I was okay. All those feelings of not worthiness and being different and feeling like I was misunderstood, that all went away. So to me, this is my solution, right? Like this is, I love this. This is what I'm going to do. So it progressed. And as everyone knows that addiction is a progressive illness, right? So, through high school, I drank and I smoked marijuana. After that, when I graduated high school, that's kind of where the other drugs kind of took place. I ended up doing pretty much everything you can think of. However, I always said to myself, I will never touch heroin. I would never touch heroin. I could do anything else, but I will not touch heroin. That is like the evil of all evils, you know? And I knew everything about heroin. I heard about it, you know? I knew the stories that people's lives were destroyed because of it. So I swore I would never do it, which all my nevers came true. However, so in my 20s, I did. I drank and did drugs the entire time. I somehow, by the grace of God, did graduate college. And I look back now on that. I believe that happened because now today I can use my experience to help the next addict and alcoholic in this field that I absolutely love doing. So I did, through all that, graduate college, you know, but my life started, it was just manipulation and lying and hurting people. And what ended up happening eventually was in my late 20s, I started with the narcotics. I stopped doing every other drug and absolutely fell in love with the narcotics. I was not prescribed narcotics. I would buy them off the street. And eventually, really what ended up happening was there was a woman I was introduced to, and she had cancer, and she was prescribed all these narcotics, and she wanted someone to sell them for her because she needed money. Ding, 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 ding. You know, here I am like, yeah, I'll definitely take those and I'll sell those. And I'm going to tell you they're $10 a pop when really they're $50 a pop, you know? So I'm making all this extra money on the side and I'm taking some extra pills and she doesn't know it. Well, what do you know? Next thing you know, I'm not making extra money. I'm taking all the extra pills. And then what ends up happening is I take all the pills and I can't pay her money and she cuts me off. And now I have a serious, drug addiction where now I'm withdrawing. These are Oxycontin 80 milligrams. And I have a major pill problem at this point. So now here I am. I have to buy these pills that are $50 a pop, and I have to take them or else I will go through withdrawal. And at the time, you know, I didn't really know anything about recovery. I didn't really know anything about addiction. All I know is like this was a part of my life. I always used some kind of substance. So what ended up happening was I had a boyfriend at the time. We were together for 6 years and we used our entire relationship, and he was involved also with the pills. So now both of us were like partners in crime and we're trying to find money and we need to get these pills. So the one night me and him are both withdrawing, so we call our drug dealer and he says, I don't have anything, but come over, I can drive around and see if I can find some for you. So we get in the car, we pick him up, we're both drug sick, and we're driving around and this guy cannot find anything, but he says to us, he's like, I can't find pills, but I got dope if you want it. And I will never forget that moment because we both looked at each other and we both kind of like, terrible idea, but I'm really sick, so let's do it. Great idea, right? Because after that night, my entire life changed completely, and I never touched a pill again. I was completely and utterly in love with heroin. Within a month, I lost everything in my life. I was unemployable. I lost my apartment. I lost the trust and relationships with my family. I was a thief. I was a robber. I was doing sexual favors to get drugs and money. Everything that you hear of, an addict, like a heroin addict, was me. And looking back now, it's crazy to me because to see the progression of the illness and to see that I had no control whatsoever. My addiction had complete control over me. And I could not stop without asking for help. I tried so many times. Oh, I'll just do it on the weekend, or I'll just save a little here, or I'll do so many bags a day. It never worked, and what ended up happening was, my solution as a child, which was, okay, it started with alcohol, right? I feel like this way, so I'm using this and suppressing all my feelings, and now that was my solution, and here I am, and it's no longer a solution. It's added to my problems. So, at that point, what ended up happening was My ex-boyfriend broke up with me. He ended up going to rehab. I swore up and down I was not using, you know, even though I'm nodding out. I'm at a NA party with him, and I'm nodding out into a bowl of food. Like, how embarrassing that must have been for him, right? So anyway, to make a long story short, we broke up. So what ended up happening for me was now my partner, I don't have my partner in crime, and here I am. It's a 24/7 thing. Before my eyes open up in the morning, I'm thinking, okay, how am I gonna get money today? I have about an hour and a half till I start withdrawing. Like, this was every day, over and over. I mean, I was living in hell itself. You know, I had lost my soul. I was the walking dead, you know. So the day I surrendered to the disease, and I surrendered knowing that I needed help, I look back now and it was all my higher power. To make a long story short, because I think it's kind of interesting how this all went about, and it's actually kind of funny, I think it is looking back now, but so my parents ended up letting me stay at their house. Granted, padlocks all over the house, okay? My sister's also in recovery, so between me and her, my poor parents, we stole everything, you know? So they did. They let me sleep over, and I remember, I'll never forget, I was sleeping in my brother's bed. I woke up in a state of panic. Okay, I gotta go get, money, and I was starting to feel sick. So, I tried my best. I had this thing I did for money, and it has to do with gasoline, and it's a really long story and ridiculous, so I'm not even going to get into that. So, but a part of that is, that's where I was going to go. I was going to go out to my car and do this little hustle thing, like I don't have gas and blah, 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 and try and get money from people. And I ended up going out to the car, and I go to turn the car on, and the car won't start. So now I'm like in a state of major panic. So me being delusional, the delusional addict that I am, I'm gonna fix the car, and I'm gonna be able to drive off, go do my thing, get high, and be okay. So I end up going into my parents' house, and my dad has a toolbox. Now granted, it's no good tools, because if they were good tools, they would have been pawned, right? But I get like a screwdriver, wrench, and like needle nose pliers, and here I am out in the car trying to fix this car. I knew nothing about cars. I'm under the steering wheel messing with wires, and like, I don't even know what I was doing. I was so not right in my head, you know? This went on for about a half hour until I realized, Amy, you're not starting the car. And I remember putting the tools down and sitting there and just started hysterically crying. Like, I was so beaten. I was exhausted. I was so unhappy. At this point, I wanted to die. Like, I wasn't a suicidal person, but I prayed, God, please take me. You know, I felt like there was no point in living. And this is when I made my first honest prayer, and that was, God, please help me. So I called my ex-boyfriend, and I said, I need to go to rehab. And he was like, thank God, you know. I got clean January 29th, 2014. And the crazy part is looking at the statistics tonight, from 14 to where we are now, deaths have risen so much. And I feel so blessed to have, realized at that time that I needed help, because there is a very good chance that I would not be standing here today. And that's all due to the supports that I got moving forward once I got to detox. I ended up going to detox. I stayed for rehab, and then I decided to move to a recovery house in Pottstown. I am from Norristown. I went to Eagleville. I went to a girls' recovery house in Pottstown with the help of IOP. The fact that I work in a rehab and detox center today, I've been there, so I know how much that has helped me move forward in my recovery. I learned so much in detox about the disease of addiction. I had no idea what I suffered from. I had no idea. So how can you really stop something when you don't understand what you have? So learning about the disease of addiction, learning new coping skills, that was a big thing for me because I used for 22 plus years. So my way of handling a situation is, I'm gonna go get high. So now I have to relearn everything. And that was the beauty about going to detox and rehab. I really got a lot out of that. And then they helped me get into IOP, which, I had a counselor for a year, and I absolutely adored her. And she helped me so much through my recovery process. I did group therapy. There was a women's group I absolutely loved. These are all the things that helped me get to where I am today. Above all, I am an AA. And without AA and my higher power, I definitely would not be here today. So the 12-step program is huge for me in my recovery. So I dove into AA, and I dove into my recovery like I dove into the things that I did for my addiction. I remember walking down Norristown in the middle of the snowstorm. I have jeans on, holes in my sneakers, and a little shirt, and I'm freezing. And I walked probably 2-3 miles to get 2 bags of dope, and then walked all the way back. I was cold, so I hitchhiked. And this guy, I don't know who, picks me up. There's so many things that I, should not have done, or I got lucky that things didn't happen to me, that when I got clean and sober, I realized I did these things. So what am I willing to do? I'm willing to do anything, because I don't want to live like this anymore. The most amazing part of this whole thing is understanding the disease of addiction and understanding what I need to do to maintain my recovery. Through AA realized, and they talk about it now, AA, started in the 30s. So the scientific stuff wasn't up to date enough, right? That we know now, we understand why it's a disease, right? But back then, they had doctors who couldn't understand why they could not heal an alcoholic or a drug addict. And what ended up happening was, there was this really well-known doctor, and he had worked with this one patient who was a chronic relapser who kept coming back. And what they do is they would detox them, in the hospital, but then there was nothing else. So they ended up relapsing, coming back. And eventually what ended up happening was there was a patient of the doctor, and this is a really well-known doctor throughout the United States. And he said it was devastating at some point to his job, because I'm a doctor, I'm supposed to be helping people, and there's nothing I can do. And he deemed them hopeless, hopeless alcoholics. Until one day this guy came to him, and he was an old patient, and he said to him, listen, I think I found a way to help alcoholics. And he started speaking about talking to the next alcoholic about their disease, connecting on that level, and this was the beginning of AA. And after the doctor, kind of watched these things, and this man would go in and he would talk to everyone there, and this is like how the groups kind of started. It was very spiritual, find a higher power, they started realizing that people were starting to recover from this disease. My whole point of the story is the doctor ended up coming up with his theory, and his theory was that alcoholics have an allergy. And I absolutely love the way they talk about this, and this is in the big book. So let's say I'm allergic to strawberries, okay? I eat a strawberry and I have a reaction. What's the reaction? I break out in hives and maybe have asthma or wheezing, right? Allergic to strawberries, I have a reaction. Well, the alcoholic. I'm allergic to alcohol. I drink alcohol and I break out in a reaction. What's the reaction? Physical cravings and mental obsession, okay? And this is how the doctor explained it, and it's absolutely true. That physical craving, and they call it the phenomenon of craving, because it's something that happens that cannot be explained, and it truly happens, So this is how the doctor explained it, which I think makes complete sense for the addict that I am. As I moved forward in AA and I started learning these things, plus all the help from, the community resources, I started to realize what I needed to do to stay clean and sober. And that was, to stay participated in the 12-step program. I do AA, I do commitments, I sponsor women, I've been through the 12 steps, I work in the field, I pick up commitments, you know, and it's not a chore for me today. Like, I absolutely enjoy it. It is a part of who I am. It makes me feel good. And above all, what all of this in my recovery has done for me is, well, real quick, just going back to the allergy. So I've realized that I can't put any substance in my body or I will have that reaction. And what is my medicine? So strawberries, you break out in hive, maybe you take some Benadryl, right? So with my reaction, I need to stay plugged into a program and stay plugged in with my higher power. You know, so that is what has been helping me and has been helping millions of people recover in the world, you know. But so in this process, I can say the best part of recovery is that I have a sense of peace today and I like myself. It doesn't matter any material things. I always thought like I had to have this big house and this car and have this like perfect family and have this, everything had to look right. Well, guess what? Everything doesn't look right today, but that's okay because I have what I need, you know, and I like who I am, and I can put my head down at night and go to bed. I could never do that before. I had to be intoxicated in order to go to bed. You know, I didn't want to think ever. I didn't want to look at myself ever. And today, I'm completely blessed with a sense of peace, a sense of liking myself. I found a fantastic man in the 12-step program, and we are engaged. And we had a beautiful son together. I have a 1.5-year-old son, Jackson, who I absolutely adore. I've mended relationships with those I thought who would never speak to me again. I guided my sister into AA, and she now has 2 years recovery. I mean, my career, you know, being able to be a good employee, you know, I never thought I was able to do that, you know. I have been blessed more than I ever thought I could be. And like I said, it has nothing to do with having a big house or having a beautiful car, even though I did just get a car and I love it. But you know, that it's not $100,000 car. You know what I'm saying? Like it's just something doable, right? For the snow and my child being safe in the car. But anyway, but I can do that today. You know, I can have a car payment and make the car payment on time. You know, I'm fixing my credit. My credit has improved so much. It was like ridiculously low because I owed everybody money, you know. Anyway, so these are some of the benefits of being in recovery. And, you know, my big thing is to spread the word of hope, you know, that it can happen, that you can recover. But my biggest thing also is to talk about the resources. I think is really huge. I really think that if we didn't have a detox program or a rehab program, I don't know where I would be today. Where would I have gone? You know what I mean? Detox was so brutal. I don't know if I'd be able to do it without being on a medication to get through it. You know, I mean, people do it, but you know, I don't know. So anyway, I'm just so blessed to be able to be a part of this today, a part of, you know, the addiction process, you know, and the recovery process. I'm blessed that I'm not a statistic that's up there, and it is an epidemic. I have, in my previous job, I was a counselor at a halfway house, and so many clients from there overdosed and died, not in our facility, but after they left our facility. And it was, you know, it's a really sad thing. I've had personal friends die in overdose. So it's real, and I think it affects every family one way or the other. And so, yes, I think the fact that we are all here together today, trying to move forward with, you know, preventing these overdoses and, you know, being, you know, having this awareness to people and education to people, I think so important. So I rambled on. So thank you very much. That's all I have.
Thank you, everyone, for coming out. The senator had to head out, but again, thank you to our panel for coming out and speaking to us. This is obviously a very in-depth issue. This is an issue that affects everyone, not just one type of person or one group of people. And hopefully this was beneficial for everyone here in the crowd. Hopefully you can take the knowledge you learned here today, spread the word, and hopefully we can do more of these. Hopefully we can get more people to come to these. I know the commissioner's office has said that they're going to be doing more. This doesn't look like it's ending anytime soon. This is affecting many people. Our office is glad that we were able to do this. I know when we were originally contacted, we were contacted by both people from Narberth, people from Norristown for us to get this done. So that should give you an idea of just how widespread this is. Everyone is affected by this. We've gone, it's 8 o'clock now. I would like to take questions, but I don't want to keep anyone here too much longer. So if the panelists do want to stick around for a couple minutes, you can come up and talk to them if they have a couple minutes to speak, but I don't want to hold people here too much longer, and hopefully we can do one of these again. Again, thank you all for coming out.